man with hemoptysis and cardiovascular disease. So why don't you go ahead and start?
Hey, good afternoon, everyone. Thank you for joining us. I'm student Dr. Ramzi Hasuna, and on behalf of Group 11, we'll be presenting a case on the 77-year-old male with hemoptysis and cardiovascular disease. So these are the members of Group 11, and I'll begin with discussing the clinical presentation of this case. The patient in question is a 77-year-old male with a medical history of type 2 diabetes mellitus, hypertension, coronary artery disease, congestive heart failure, paroxysmal atrial fibrillation, and chronic renal insufficiency attributed to nephrosclerosis. He also has a long history of smoking. 2 years prior to admission, the patient was diagnosed with a leaking abdominal aortic aneurysm and was repaired at a different hospital. 10.5 weeks prior to admission, he was admitted to the Massachusetts General Hospital for worsening back pain. Upon examination, it was revealed that he has a descending thoracic aortic aneurysm, which was greater than 8 centimeters in diameter. According to recommendations, surgical intervention is required when it's beyond 6 centimeters in diameter. This was repaired with a technique called left atrial femoral bypass, and this was used due to his chronic renal insufficiency and to maintain perfusion to the renal arteries throughout the surgery. 6 weeks prior to admission, on follow-up, a radiograph of his chest showed slight cardiomegaly, pulmonary vascular congestion, bilateral pleural effusions, and an ectatic tortuous aorta. A cardiac ultrasonograph showed left ventricular hypertrophy and an aortic stenosis. Therefore, the patient was transferred to a rehabilitation center for monitoring. Another follow-up 6 days prior to admission, a radiograph of his chest showed cardiomegaly. However, this time there was slight mediastinal widening. This is characterized as a mediastinum greater than 8 centimeters in diameter on an anterior-posterior chest X-ray. The chest X-ray also showed asymmetric airspace disease, which is accumulation of fluid in the alveoli, and this was asymmetric to the left side of the patient. 3 days prior to admission, the patient complained of increasing pain on the left side of his chest. Prior to arrival on the morning, the patient complained of anterior chest pressure. He was later found unresponsive with agonal breathing. His vitals revealed a stable heart rate, however, a low blood pressure, which is considered hypotensive, of 90/50. A tracheal tube was inserted, and this resulted in a hemoptysis of 250 milliliters of blood. And this is characterized as a massive hemoptysis since it's greater than 200 ml of blood in a 24-hour period. Following arrival, once the patient was alert, he was given a normal saline bolus, which brought his blood pressure to normal levels of 125/75. His vital signs were later taken, showing a stable pulse, breathing rate, blood pressure, and O2 saturation. However, his temperature was below normal, suggesting reduced perfusion throughout his body attributed to his cardiac insufficiency. Physical examination showed a weakened carotid pulse of +1/4, and upon auscultation, a grade 2 systolic ejection murmur was heard at the base of the heart, highly suggestive of an aortic stenosis. Further diagnostic testing included an ECG, which showed a normal rhythm and normal heart rate, however, a first-degree AV block with an extended PR segment. Anterior lateral leads V through to V6 showed inverted T waves, suggesting left ventricular hypertrophy and myocardial infarction. A gastric lavage revealed no upper GI bleeding. A chest X-ray was performed on the patient, and as you can see, compared to the normal chest X-ray on the left side, the patient has quite a bit of mediastinal widening. The patient also has airspace disease on both sides with accumulation of fluid in the alveoli. The patient also has cardiomegaly with left ventricular hypertrophy, as well as pleural effusions on both sides. A CT scan of his chest showed calcification on his aortic arch, suggesting stiffening of the structure. Another CT scan showed airspace disease in his alveoli, as well as pleural effusion, mostly localized to the right side of the patient. His lab values showed significantly reduced hematocrit as well as platelet count attributed to his massive hemoptysis. Urea nitrogen and creatine, which are markers of renal function, were significantly increased, suggesting renal insufficiency. Markers of myocardial infarction, such as creatine kinase and lactate dehydrogenase, were well within reference range. He was then given quite a few medications to control his symptoms, including procainamide, an antiarrhythmic, ipoetin and ferrous sulfate for his loss of blood, sodium bicarbonate for his pH, ethacrynic acid, a diuretic to control urine output, an albuterol inhaler to help with his breathing. He was placed on vasopressor therapy to control his blood pressure, and he was then transfused with packed red blood cells to bring his blood count back to normal. On day 2, a bronchoscopic exam showed less blood in airways, and a radiograph of his chest showed increases in pleural effusions. The morning of day 3, the patient complained of trouble breathing at rest. Lab values showed further decreases in complete blood count, and therefore the patient was given 3 units of packed red blood cells. A chest radiograph was unchanged in that it still showed quite a bit of pleural effusions. The patient also coughed up sputum containing old blood. At the evening of day 3, an ECG was performed which revealed atrial fibrillation, as well as depressed ST segments in the anterior lateral leads V3 to V6, suggesting myocardial infarction. The patient was administered the antiarrhythmic verapamil, the diuretic ethacrynic acid, which brought his rhythm and rate back to normal. The patient also complained of severe abdominal pain, and upon auscultation, he had reduced bowel sounds. Physical examination showed mottled legs, suggesting reduced perfusions to the leg, and this can be attributed to his cardiac insufficiency. The evening of day 3, a radiograph showed further increases in right-sided pleural effusions, as well as increased left-sided airspace disease. A CT scan of his chest at the evening of day 3 revealed a new finding on his aortic arch. As you can see by the white arrows, there's a crescentic opaque structure on his aortic arch, suggesting perhaps an aneurysm or a dissection in the structure. Lab values on the evening of day 3 showed further increases in urea, nitrogen, and creatine, suggesting further diminished renal function. Markers of myocardial infarction, such as creatine kinase, its MB fraction, lactate dehydrogenase, and lactic acid were significantly increased. Finally, on the evening of day 3, a preoperative transthoracic and transesophageal echocardiographic study were performed. However, the patient was deemed unable to tolerate surgery. Upon consultation with the family, it was decided to remove the patient from vasopressor therapy, which resulted in the patient's death. I'll now hand it over to student Dr. John Heal to discuss the differential diagnosis.
Thank you, student Dr. Ramsey Hasuna. My name is student Dr. John Heald, and I will be presenting the differential diagnosis pertinent to this case. To begin with, the patient presented to the emergency department with 3 predominant clinical features: hemoptysis, hypotension, and syncope. The discussion of differential diagnosis will focus on the causes of hemoptysis, as hypotension and syncope were determined to be secondary to this. The underlying causes of hemoptysis can be broadly divided into 3 categories, including infectious disease, autoimmune disease, and cardiopulmonary disease. I will begin the discussion of differential diagnosis by discussing infectious disease pertinent to this case. Hemoptysis in the context of pulmonary tuberculosis can be pathognomonic of pulmonary tuberculosis. Rasmussen's aneurysm represents a source of massive hemoptysis from TB infections, but is usually only seen in approximately 7% of patients. Next, necrotizing pneumonia was an unlikely cause for the hemoptysis seen in this patient due to the lack of leukocytosis and the patient being afebrile. Additionally, bronchiectasis was ruled out following CT imaging, and broncholithiasis was ruled out following radiographic exam. This eliminates the infectious disease causes pertinent to this case. I will now discuss the autoimmune disease causes of hemoptysis. To begin with, systemic lupus erythematosus is considered in many differential diagnoses due to its chronic inflammation affecting many organ systems. Classic symptoms of systemic lupus erythematosus include the development of a characteristic butterfly-shaped rash on the patient's face, sensitivity to light, and arthritis. Due to a lack of these symptoms observed in this patient, this disease was excluded from diagnosis. Next, granulomatosis with polyangiitis usually presents with low-volume intermittent hemoptysis. However, the single event of massive hemoptysis in this patient, in this case coupled with the normal findings on upper airway exam, led to the exclusion of this disease as a diagnosis. Next, Takayasu's arteriitis is an autoimmune disease of the vasculature that primarily affects the ascending aorta and its divisions. Ultrasonographic examination did not show evidence of aortic stenosis leading to Takayasu's arteriitis being ruled out. Finally, Goodpasture syndrome results after the development of autoantibodies against collagen in the alveoli of the lungs and glomeruli of the kidneys. Anti-GBM antibodies were not noted in this patient, leading to its exclusion. This eliminates the autoimmune disease causes of hemoptysis. I will finish by discussing the cardiopulmonary disease causes of hemoptysis. Because of the patient's long history of smoking, cancer was suspected as a possible cause of the hemoptysis. However, diagnostic findings from radiographic and bronchoscopic exam were not suggestive of cancer. Next, pseudoaneurysms can arise as post-operative sequelae. Progression of pseudoaneurysms leads to pressure necrosis and compensatory fistula formation. Due to our patient's past surgical history, a pseudoaneurysm was considered and could not be ruled out prior to the autopsy. For patients that do develop aortobronchopulmonary fistulas, they usually present with constant chest or back pain, cough, dyspnea, and hemoptysis. Due to the patient presenting with many of these symptoms, this was also considered as a source of the hemoptysis and could not be ruled out prior to the autopsy. Finally, aortic dissections act as extraluminal conduits for the movement of blood within the vessel. In this patient, upon CT examination, a crescentic extraluminal soft tissue abnormality was noted, suggestive of an aortic dissection. Again, this could not be ruled out prior to the autopsy. Based on the patient's presentation of chest pain, hypotension, syncope, and hemoptysis, along with supporting CT evidence, led the physicians to a clinical diagnosis of a dissecting aneurysm of the aorta with an aortobronchopulmonary fistula with aortic insufficiency. Upon the patient's death, an autopsy was performed. I will now present the findings. The image on the left of the screen corresponds to the dissecting aneurysm in the patient's ascending aorta. The tissue on the right of the image corresponds to the tunica media of the vessel, with the arrowhead pointing to the dissecting channel. The long arrow corresponds to a 1 centimeter tear through the intima of the vessel. The image on the right of the screen shows a CT scan of the patient's thoracic cavity, with the series of red arrows pointing to that crescentic extraluminal soft tissue abnormality that was highly suggestive of an aortic dissection. This image diagrams the extent of the aortic dissection. Beginning on the anterolateral aspect of the aorta, blood entered here between the media and intima of the vessel, extended superiorly and distally to involve the brachiocephalic trunk, the left common carotid, and left subclavian arteries. Retrograde dissection extended to the point of exit, marked on the diagram at the aortic annulus. Here, blood erupted through the periadventitial adipose tissue to form a subepicardial hematoma. This pooled blood further led to the development of subendocardial hematomas in both atrias of the heart and occlusion of a coronary artery at the base of the pulmonary trunk. Macroscopic examination of this area did not reveal a re-entry point for blood back into the right ventricular outflow tract. However, on histological examination, it was noted there was a myocardial infarction noted of 3 days duration. This corresponded to the patient's syncopal attack. Finally, blood from the base of the heart crossed the pulmonary hilum through the adventitial tissue of the bronchovascular bundles to the periphery. Blood also entered the lamina propria of the bronchi and thickened the mucosa focally. This was the source of the patient's hemoptysis. This image shows the re-entry of blood back into the right ventricular outflow tract at the base of the pulmonary trunk. The arrow on the left of the image shows blood transversing the adipose tissue at the base of the pulmonary trunk, with the middle arrow pointing to the pooling of blood beneath the endocardium near the insertion of a pulmonary valve cusp. Finally, the arrow on the right of the image points to necrotic myocardium. This image shows the accumulation of blood in the left lung around the blood vessels and bronchi, again, the source of the patient's hemoptysis. Finally, this image shows the linear spread of blood from the hilum of the left lung through the interstitium along a bronchus. Based upon the physical findings of the autopsy, the patient was diagnosed post-mortem as having a dissecting aortic aneurysm with rupture into the epicardium, interatrial septum, right ventricular outflow tract, and lungs, with an acute myocardial infarction of the right ventricular outflow tract and severe coronary artery disease. I will now turn the presentation over to student Dr. Brad Haynes.
I would like to thank student Dr. John Heald for his presentation on the differential diagnosis of our case. My name is student Dr. Brad Haynes, and I will be presenting the treatment options, ethical concerns, and conclusions of our case. As mentioned previously, our patient suffered from a dissecting aortic aneurysm that led to massive hemoptysis and his death. To better illustrate the severity of the dissection in this case, I will begin by taking some time to discuss the classification systems that are used when referring to dissections that occur within the aortic arch. Because the Stanford system is more commonly used when referring to dissections that occur within the aortic arch, I will expound upon only this system. Within the Stanford system, dissections can be placed under one of two subcategories. These subcategories include the Stanford Type A and Stanford Type B dissections. In a Stanford Type A dissection, the origin of the tear begins in the ascending aorta, which can then propagate upward and involve the aortic arch. In a Stanford Type B dissection, the tear originates in the descending thoracic aorta regardless of any movement upward that can involve the aortic arch. The patient in our case suffered from a dissecting aortic aneurysm of the Stanford Type A classification system, which propagated upward and involved the brachiocephalic trunk, as well as the left common carotid and left subclavian arteries. By far, the most common form of treatment for patients suffering from a Stanford Type A dissection is surgery, with roughly 80% of patients undergoing surgical repair. Furthermore, a Stanford Type A dissection is considered a surgical emergency, with the mortality rating increasing by a minimum of 1 to 2% per hour early after onset. To complicate this case further, there are many contraindications to surgery that can deem one unfit for surgical repair. Such contraindications include when the patient is over 70 years of age, experiences abrupt onset of chest pain, is hypotensive, experiences renal failure, has had prior myocardial infarction, or has an abnormal ECG. The patient in our case suffered from each of these contraindications, deeming him unfit for surgical repair. Had the patient in our case been deemed fit for surgical repair, there are several procedures that could have been performed to repair the dissection. One particularly worth mentioning is the use of an open triple-branched stent graft placement. This is particularly useful in cases such as ours because it repairs not only the aortic arch, but also the brachiocephalic trunk, as well as the left common carotid and left subclavian arteries, all of which were damaged in our case. Another potential treatment option that is less invasive could have been the use of an endovascular stent. This uses a tube composed of fabric combined with a metal mesh for structural support. At the time of this case, the use of endovascular stents was still being proven a valid treatment option for dissections that occur within the aortic arch. However, recent research has continued to demonstrate that the use of endovascular stents in such dissections is possible. While it appears likely that the patient in our case would have suffered from the same outcome regardless of if physicians had caught the dissection earlier, we still feel it necessary to discuss the lack of acquisition of history for our patient. Given our patient's previous history of aneurysms, it can be expected that had a better history been taken, The diagnosis of our patient could have been acquired in a more appropriate time frame. Another important bioethical issue worth mentioning is the lack of any discussion of the acquisition of an advance directive for our patient. Given that our patient presented 10 weeks previously to this same clinic with another aortic aneurysm, communication between the physician and the family and friends could have been done to explain the benefits of acquiring an advance directive for this patient that would have allowed the family to better execute the will of the patient. In conclusion, while we feel that it is likely that even had the physicians acquired a better history of this patient, our patient's previous medical history, as well as the contraindications for surgery that deemed him unfit for surgical repair, all lead us to the conclusion that the outcome of this case was inevitable. We would like to thank all those that participated in helping us prepare this presentation. Here are our references, and we are now ready to take any questions at this time. Thanks.
Rounds. We were probably breathing a sigh of relief right at the moment. So I know you got some questions from the audience. Why don't you go ahead and maybe start some of those?
So one of the questions was, what is the mechanism of action for procainamide? And if you remember, that was the antiarrhythmic agent that they gave him when he came in on day 1. And the main purpose of procainamide is to suppress ectopy in the atrial and ventricular tissue, so it disallows fibrillation and flutter. And it does this by inhibiting the influx of sodium through the membrane pores, so it prolongs the effective refractory period, so it gives more time for recovery in the tissue.
Okay, the next question was, why was respiratory anthrax infection not even considered as a possible differential? And our patient was afebrile, so respiratory anthrax would cause a fever, and he was also had no nausea or sore throat, which are also symptoms of respiratory anthrax.
The question was asked because he had a widened mediastinum, and I know you had another question about what are some causes of a widened mediastinum. So whoever has that, you might grab that.
I'll go ahead and take that. So, as Dr. Dubin said, the question is, what are other causes of mediastinal widening? And other causes include aortic valvular stenosis, a type of hematoma from an aortic injury, large B-cell lymphoma, esophageal perforation, mediastinal mass, sarcoidosis, and respiratory anthrax.
Don't forget thymomas in the anterior mediastinum.
And thymomas in the anterior mediastinum.
Any other questions? No, you have a few more.
One of the questions was what kind of vasopressor therapy can be used. So short-term or a quick-acting vasopressor therapy would be catecholamines. An example of that is epinephrine or norepinephrine, and those work by acting on alpha and beta receptors. They vasoconstrict the vessels throughout the body, increase heart rate, and increase cardiac output, therefore bringing blood pressure back to normal.
One of the questions was, how does albuterol work? And it's a moderately selective short-acting beta-2 agonist, and it leads to smooth muscle relaxation. It's a mix of R and S isomers, and the R isomer is the one that primarily does bronchodilation in humans, and it's mediated by cyclic AMP.
So the next question is, what is an ectatic tortuous aorta? So it's a more, the shape takes more of a curve than usual. And also, what are the causes? And it is due to age-related degeneration, and also in a recent study, the natural history of ectatic abdominal aortas in a group of median age of patients around 71 years, which is close to our patient, was due to coexisting risk factors including hypertension, ischemic heart disease, peripheral vascular disease, diabetes, chronic obstructive pulmonary disease, stroke, popliteal aneurysms, and malignant disease, as well as previous abdominal aortic aneurysms.
Yeah. How common are aortic aneurysms? And according to the United States data in 2009, there was about 11,000 deaths that were primarily from aortic aneurysms, and they're due to, besides natural aging and wear and tear, you can get them through high blood pressure, atherosclerosis, and again, normal wear and tear. So lifestyle modifications, exercise, and weight loss can help limit the onset.
So, one question I have, this is a Stanford type A aneurysm. A little while ago, if this was a member of your family who came in now at 73 years of age, and you now have the availability of a stent, what would you do? Would you go ahead and try that, or would you look at the contraindications still and say, you know what, you're an old guy, thank you very much for your time?
Even with the stent, there are contraindications to it, such as, for instance, in this patient, he had renal failure, and none of the stents were placed in patients with renal failure.
So you're kind of an absolutist, and you just say sorry.
Yeah, you don't meet the criteria, sorry. No, I'm just kidding.
Okay, so it's probably a job for you somewhere at the Affordable Care Act, I'm sure, but...
I mean, the thing about this is the aortic dissections require, especially type A, require surgery. That's how to fix them. Without that, they're going, I mean, I think the average lifespan is 2 weeks without surgery, so trying something may be better than nothing.
Okay, fair enough. I'm just giving you a hard time. Any other questions?
Yes, I had another. So can poor perfusion affect the ability to measure the O2 saturation? So using like pulse oximetry, which is the non-invasive measurement of oxygen saturation, poor perfusion due to hypertension, hypovolemic shock, cold environment, or even cardiac failure can result in the machine not providing an accurate reading.
Okay, especially true in a patient with mottled skin like you saw earlier in your case. All right, guys, this is a great presentation. Thank you very much. Good job, and let's get our next group up.
Hello? Hello?
Hello, everyone, and thank you for attending our presentation of a 22-year-old male patient with a past medical history of cardiac transplant who presents with elevated creatine kinase. I'm student Dr. Chase Hobbs, and I'll be presenting this patient's initial presentation and history. At age 22, this patient presented to clinic with complaints of mild muscle cramping in his triceps, shoulders, and upper back muscles. These symptoms generally occurred in the morning and were relieved after stretching. At the time of his presentation, enzyme measurements were also taken. These revealed a creatine kinase level of 1,298 units per liter and a spartate aminotransferase level of 48 units per liter. Creatine kinase is an enzyme responsible for the reversible catalysis of ATP and creatine to phosphorylcreatine and ADP and vice versa. In tissues that consume ATP rapidly, such as muscle cells, phosphorylcreatine serves as a source of rapid regeneration for energy. Therefore, increased levels of creatine kinase in the bloodstream can be indicative of muscle tissue damage. Aspartate aminotransferase, otherwise known as AST, is an enzyme involved in amino acid metabolism. It is found in high concentrations in the liver, heart, skeletal muscle, brain, and kidneys. AST is clinically used as a biomarker for liver health, and its elevated presence in the bloodstream is a good indicator of liver damage. Less specifically, it is also a good indicator of muscle tissue damage. This patient has a past medical history of congestive heart failure, which is a clinical diagnosis that was made when the patient was 17 years of age, 5 years prior to his current presentation. A diagnosis of myocarditis was also made via a left endomyocardial biopsy, in which a muscle tissue sample is taken from the internal chamber of the patient's left ventricle and stained using hematoxylin and eosin. This diagnosis of myocarditis confirmed his clinical presentation and subsequent diagnosis of CHF. The following is the stain of the patient's left ventricle taken, as aforementioned in the previous slide. On H&E stain, myocarditis is characterized by damaged myocardial fibers as well as an inflammatory infiltrate rich in the presence of lymphocytes and immune cells. As we can see here, a normal cardiac myocyte, the cytoplasm stained with eosin in the pink here, and then the hematoxylin staining the nuclei in blue or dark purple. Over here we can see destroyed cardiac myocytes or damage, which would cause the leaking enzymes into the bloodstream, and here an inflammatory infiltrate rich in the lymphocytes, all the nuclei of which are stained with hematoxylin. Myocarditis refers to an underlying disease process that causes inflammation and tissue injury of the heart. There are many disease processes that can result in myocarditis, and it is important to determine the underlying cause when dealing with a patient. Our patient developed his CHF secondary to his myocarditis. However, the etiology of the myocarditis was unknown at the time of his presentation. Following this diagnosis, the patient was started on standard treatment regimen for congestive heart failure. The patient was treated for 1 year. However, no improvements were seen, and 1 year later, the patient was found to have worsening heart failure. Over the next 20 months, a series of left endomyocardial biopsies were taken. The following photo is of an endomyocardial biopsy taken 1 year prior to his initial biopsy. This photo reveals bands of fibrosis, as seen here, where healthy cardiac myocytes once existed and have now been replaced by excess connective tissue as a reparative process. We can also see myofibril hypertrophy, as indicated down here in the right corner, with enlarged cardiac myocytes and enlarged nuclei stained with the hematoxylin. The presence of an inflammatory infiltrate indicative of an acute inflammatory process is no longer present. These signs together indicate a healed myocarditis. However, tissue damage still remains, and the heart will continue to function at a decreased capacity. At this point in time, it still remained unclear as to the etiology of the patient's heart disease. Due to these symptoms and the pathological changes in the heart, as well as his young age, an orthotopic cardiac transplantation was performed. The patient experienced episodes of graft rejection 2, 5, and 9 months post-transplant. Each of these instances was successfully managed with corticosteroid treatment. It is also worth mentioning that prior to the patient's surgery, his creatine kinase and aspartate aminotransferase levels were within normal limits. This patient was subsequently stable until 18 months later when he presented with muscle cramping, creatine kinase of 1,298 units per liter, and aspartate aminotransferase of 48 units per liter. This brings us up to date with the patient's current presentation at age 22. Due to these symptoms and elevated enzyme levels, he was referred to neurology. When presenting to neurology, the patient continued to complain of muscle cramping symptoms. His review of systems was otherwise unremarkable, and he had no other complaints at the time. Physical exam showed the patient appeared healthy and well, and an extensive neurological exam was unremarkable. Chest radiography revealed no abnormalities, and electromyography and nerve needle conjunction studies were also performed, which were unremarkable and revealed no abnormalities. The purpose of these diagnostic tools is to evaluate the electrical activity of motor and sensory neurons. They can detect any abnormal neuronal activity or loss of neurological function. This patient is also noted to have an extensive family history of cardiac disease on his mother's side. The patient's brother was diagnosed with congestive heart failure at age 20 and required treatment with digoxin. Two other siblings, or members of the patient's family on his mother's side, deceased in their teenage years of cardiac disease, and one other in their 50s of myocardial infarction. The females on the patient's family were not indicated to have any history of cardiac disease, as well as one of the maternal aunts having 3 healthy sons. At the time of the patient's presentation, the etiology of cardiac disease of the patient's family on the mother's side was not indicated and was not pursued in depth. The patient was on the following medications when he presented to neurology. Cyclosporin, which is an immunosuppressant drug indicated post-transplant used to suppress T lymphocytes. Azathioprine is also an immunosuppressive drug used to prevent graft rejection. It functions to suppress the proliferation of B and T lymphocytes. Prednisone, which is a corticosteroid medication that is effective as an immunosuppressant drug and also used post-organ transplantation. Ranitidine, or trade name Zantac, is a histamine H2 receptor antagonist. It is used to suppress the secretions of gastric acid, especially in patients with peptic ulcer disease or gastroesophageal reflux disease, otherwise known as GERD. It was not indicated as to the reason the patient was taking the medication at the time. Trimethoprim sulfamethoxazole is a commonly used antibiotic and is used to treat a wide array of bacterial infections. However, it is also used to treat and prevent pneumonia in immunocompromised patients. Further enzyme measurements were conducted at neurology. The patient was noted to have an elevated aldolase level of 19.3 units per liter. Aldolase is an important enzyme in glycolysis which functions to break down glucose into usable energy. This enzyme is found in high concentrations in muscle cells, especially skeletal muscle cells, and its elevated presence in the bloodstream is a strong indicator of skeletal muscle tissue damage versus cardiac myocyte damage. The patient continued to have elevated creatine kinase levels and was also seen to have an elevated creatine kinase MB. Creatine kinase MB is an isoform of creatine kinase found in cardiac muscle cells, the MB standing for myocardial band. It is a commonly used diagnostic indicator of myocardial infarction. However, CKMB can also be found in smaller amounts within skeletal muscles. Therefore, elevated CKMB is not entirely specific to cardiac myocyte damage and can also be elevated in a wide array of clinical conditions. The patient was noted to have a normal creatine kinase index, which measures the ratio of CKMB to normal creatine kinase in the blood. This index can be elevated in cardiac disease, but because this index was within normal limits, we can most likely conclude that his elevation in creatine kinase is most likely not cardiac in nature. This will be discussed further in differential diagnosis section. Enzyme measurements were repeated 2 weeks later during a follow-up to neurology and revealed the following. The patient was noted to have a minor decrease in creatine kinase. However, it did still remain elevated. It is worth mentioning that during this time, the patient was placed on a lower dose of cyclosporin medication. This may have played a role in this mild decrease in creatine kinase, the significance of which will be discussed further in differential diagnosis. His aspartate aminotransferase levels were found to be 46 units per liter, which is similar to what his numbers were before. He was noted to have a normal alkaline phosphatase levels. Alkaline phosphatase elevations can be seen in patients with bone disease or biliary obstruction. His hematologic values were all within normal limits. I would now like to introduce student Dr. John Horkey, who will be presenting the differential diagnosis of our case.
Thank you. I'm student Dr. John Horkey, and I'll be presenting the differential diagnosis. An exhaustive list of differentials can be formulated whenever a patient presents with elevated creatine kinase. For our case, we will discuss only the most relevant. During this discussion, it is important to keep in mind that this patient had 25 times the normal creatine kinase levels. In rhabdomyolysis, patients present with elevated creatine kinase and muscle cramping, which can include the shoulder region. Rhabdomyolysis is an acute massive muscle injury due to trauma, prolonged muscle compression, or seizure. However, nothing in this patient's history suggests these events occurred. Additionally, patients with this disease will present with 5,000 times the normal creatine kinase levels. In amyotrophic lateral sclerosis, patients present with elevated CK and muscle weakness due to motor neurons beginning to necrose. Although this disease typically presents in patients over the age of 40, rare cases can occur in the third decade of life. However, this patient's normal electromyography tests rule out motor neuron diseases and ALS. Infectious diseases have been known to lead to myopathies where elevated creatine kinase levels are seen. However, normal white blood cell count and no associated symptoms, such as fever, support the diagnosis of a bacterial or viral infection. The association of muscle cramps and elevated creatine kinase makes McArdle's disease a possible diagnosis. Patients with this disease have a myophosphorylase deficiency, which is the enzyme that breaks down glycogen during exercise. Thus, elevated creatine kinase and muscle cramps are seen only after exercising. This is not consistent with this patient, as his elevated CK levels are seen during rest. Furthermore, patients with McArdle's disease have elevated CK up to 100 to 500 times the normal levels, while this patient only has 25 times the normal level. It is necessary to consider chronic graft versus host disease since this patient received a recent heart transplant. While CK-MB is mainly present in the heart, it is also present in skeletal muscle, and the fact that aldolase enzymes are also elevated suggests a skeletal muscle myopathy, not cardiac. With a 22-year-old male patient, it is always important to consider alcohol or cocaine drug abuse, which are known causes of elevating creatine kinase levels. Though, given this patient's history, there is no reason to suspect such abuse. The medications this patient was currently taking could be a possible cause for his elevated CK. The corticosteroid prednisone that this patient was taking has been known to cause elevated creatine kinase occasionally, especially with long-term usage. With corticosteroid-induced myopathies, however, an abnormal electromyography test would be expected due to neuron necrosis, and this patient's EMG was normal. Because of this patient's heart transplant, he was currently using cyclosporine as an immunosuppressant that inhibits T-cell activation. In this mechanism, cyclosporine forms a complex with calcifilin inhibiting phosphatase activity of calcineurin, which regulates nuclear factor of activated T cells. Although there is not much current research on the mechanism in which cyclosporine elevates CK, there is a known association. Subsequently, an initial diagnosis of cyclosporine-induced myopathy was made, and dosage was reduced. Yet, 2 weeks later, this patient's creatine kinase levels were still elevated. The history of cardiomyopathies in male relatives on the patient's maternal side support the notion of an X-linked recessive disease affecting both cardiac and skeletal muscle. For this reason, Duchenne's and Becker's muscular dystrophies were considered. Before we discuss these diseases, it is important to understand the dystrophin protein. Dystrophin is a rod-shaped protein that functions in the structural integrity of myofibers by connecting the cytoskeleton to basal lamina, seen here. The dystrophin gene is the largest human gene known, located on the P arm of the X chromosome, spanning over 2.5 million base pairs. In the absence or reduction of dystrophin, the sarcolemma is ruined by the shearing force generated during muscle contraction. In Duchenne's muscular dystrophy, out-of-frame deletions on the dystrophin gene lead to complete absence of dystrophin. As a result, affected boys have loss of ambulation by the age of 12 and die from respiratory failure within 10 years afterwards. Since this patient is still ambulating and alive in his third decade of life, we can rule out Duchenne's muscular dystrophy. Becker's muscular dystrophy results from in-frame mutations on the dystrophin gene, which leads to only a partial loss of the dystrophin protein and is subsequently less severe compared to Duchenne's. The onset of Becker's muscular dystrophy can be early or late and present with muscle cramps and elevated creatine kinase, as seen with this patient. To confirm the diagnosis, a muscle biopsy was taken, as well as an immunohistochemical staining. Comparing the immunoreactivity in a healthy patient, seen here, compared to this patient here, it is easy to see the reduced levels of dystrophin. Additionally, dark field photomicrographs show similar findings when comparing a healthy patient's dystrophin and this patient's dystrophin. Becker's muscular dystrophy can also affect cardiac muscle in addition to skeletal muscle. That is why it is strongly believed that this patient needed a heart transplant so young. Later, the elevated creatine kinase was due to a progression of this patient's Becker's muscular dystrophy, as it was now affecting his skeletal muscle. Thus, Becker's muscular dystrophy was chosen as the final diagnosis. Now to present the treatment and ethical considerations is student Dr. Kyle Hill.
Thank you, John. My name is student Dr. Kyle Hill, and as the patient in this case was diagnosed with Becker's muscular dystrophy, I am going to discuss the treatment and recommendations for individuals with this diagnosis, as well as the comorbidities associated with the disease. Additionally, I'm going to discuss the current and emerging research for the treatment of Becker's, the ethical issues surrounding our case, and the education and resources available to patients with Becker's. It is important to note that currently there is no cure for Becker's muscular dystrophy, and the life expectancy for those diagnosed is mid to late adulthood. Current treatment options are aimed at treating and managing the symptoms associated with Becker's, like muscle weakness and wasting, difficulty breathing, heart disease, as seen in our present case, and elevated creatine kinase. Before prescribing any medication, it would be important to note if there are any contraindications for these treatments. Becker's is closely related to Duchenne's muscular dystrophy in that both are characterized by a loss of dystrophin protein. While Becker's causes a partial loss in dystrophin, Duchenne's leads to a total loss of dystrophin protein. Additionally, Becker's has a much lower rate of occurrence compared to Duchenne's and also exhibits less severe symptoms. For that reason, current research is more focused on the treatment of Duchenne's. However, because of the similarity between the two disorders, many of the treatment options are also similar. Standard drug therapy for treating Becker's is the use of corticosteroids. Corticosteroids are effective in slowing the course progression of Becker's, and prednisone is most commonly prescribed. The purpose of using corticosteroids is for their immunosuppressive effects. The reduction of pro-inflammatory proteins helps to decrease immune response-related cell damage as the muscles in Becker's patients begin to deteriorate. The prolonged use of corticosteroids, however, has many adverse side effects. For example, skin thinning, purpura, Cushingoid appearance, weight gain, sleep disturbance, and mood changes. These effects are typically dose-dependent and increase with the duration of therapy. Alternative day drug administration may be helpful in alleviating some of these adverse side effects. However, this is usually unsuccessful in adult patients who require high therapeutic dosage. Aside from medication, an important focus in treating Becker's is the maintenance of symptoms including muscle wasting, contractures, cardiomyopathy, respiratory difficulties, and compensatory dysfunctions. As the disease progresses, patients may develop contractures. Contractures occur as the muscles deteriorate and the joints begin to fixate due to a shortening of the muscle tendons. This most often happens in the lower limbs and can be painful and restrict mobility and flexibility in these patients. Physical therapy and exercises that help increase ambulation may delay the formation of these contractures. As the disease progresses, walkers, braces, or wheelchair use may be required to help maintain the mobility of these patients. Exercise may also help build skeletal muscle and keep the cardiovascular system healthy, but excessive exercise can lead to increased muscle damage. For that reason, low-impact activities such as swimming or water exercises are recommended to keep the muscles toned and prevent undue stress. Additionally, respiratory care is an important consideration due to the weakening of respiratory muscles. If symptoms become severe, non-invasive ventilation, such as BiPAP, may be beneficial. Due to the suppressed immune system that is seen in these patients from the corticosteroid treatment, there is also an increased risk of contracting respiratory infections. Ensuring patients receive a pneumonia vaccine and practice good dental and oral hygiene can help reduce this risk. Lastly, there is currently no evidence-based research concerning OMM treatment for Becker's patients. However, because this disease causes a loss of strength and wasting of muscles, it is common for these patients to develop compensatory dysfunctions, which can be treated with OMM. As mentioned, there is no cure for Becker's or Duchenne's muscular dystrophy, and current research is heavily focused on better treatment outcomes for those with Duchenne's because of its higher incidence and severity of symptoms. This has led to a gap in research that is specifically focusing on Becker's. However, because the two diseases have such similar etiology, research centered on treating Duchenne's would likely be effective in treating Becker's as well. As such, I'm going to briefly discuss the research involving Duchenne's that may have therapeutic implications for those with Becker's. The two major areas of research we chose to focus on are gene regulation of myostatin and gene therapy involving the dystrophin gene. Myostatin is a protein factor released by myocytes that acts as an autocrine signal to inhibit myogenesis. It has been shown that by inhibiting myostatin receptors in dystrophic mice, skeletal muscle mass increases. This treatment may serve as a novel therapeutic strategy for those with muscular dystrophy. Current gene therapy treatments for Duchenne's require lifelong treatments with immunosuppressants. This is necessary because those with Duchenne's will have an autoimmune response to dystrophin protein if it becomes expressed in skeletal muscle. Prolonged immunosuppressant treatment leads to an increased susceptibility to infections due to the depressed immune system. Research currently being done here by Dr. Robert White is focusing on how to express dystrophin in skeletal muscle without eliciting this autoimmune response. Human retinal dystrophin gene was used to express dystrophin in skeletal muscle of dystrophic mice. The expression of retinal dystrophin was able to partially compensate for the lack of skeletal muscle dystrophin and prevented severe and lethal muscular dystrophies. Because retinal dystrophin remains expressed in those with Duchenne's, this treatment would theoretically prevent an autoimmune response. Our case raises a few interesting ethical considerations. When the patient initially presented at age 17 with congestive heart failure, it was discovered he had a remarkable family history indicating familial heart disease. The information was not given in the case as to whether the family history was pursued in depth or if any genetic testing was performed. This situation helps to illustrate the importance of pursuing family history and genetic testing for diagnostic and treatment purposes. This question is also important when considering the patient and his ability to make an informed decision regarding his quality of life. Due to the correlation between Becker's and cardiomyopathy, it would be important for the patient to know if the new heart would be susceptible to the effects of this disease. This knowledge may have played a role in the patient's decision to receive a heart transplant. In addition, it would have likely benefited the physicians to be informed about the patient's muscular dystrophy because in 1998, at the time of this case, muscular dystrophies were considered a relative contraindication for heart transplantation. The knowledge of a Becker's diagnosis may have influenced the decision for this patient to receive a heart transplant. With the diagnosis of Becker's muscular dystrophy, it's important for those who are affected and their families to be educated about the disease. The website mda.org contains resources for patient and family education, as well as locations for support groups. As with all debilitating diseases, community and family support can help play a crucial role in maintaining the mental health of the patient. Events such as muscle walks help raise awareness and provide community support and financial aid to further muscular dystrophy research and improve the lives of individuals with this disease. At this time, we'd like to thank all the professors who helped us with our presentation. These next few slides contain the references for the content of our presentation, and we'd like to open it up to questions. Thank you.
Well done. I know you had some questions, so we'll start over here.
Okay, the first question we had was how common is CHF in adolescents or teens? And the short answer is it's not very common at all. As far as finding an exact number, I wasn't able to find an exact number, but to put it in perspective, so in adolescents and teens, there's a couple of things that could cause heart failure. One of them would be if they were born with a congenital heart defect. As far as that's concerned, it's about 1 in every 100 babies is born with a congenital heart defect, but that doesn't very often lead to congenital heart failure. As far as in this case, Duchenne and Becker's muscular dystrophy, about 1 in 5,000 newborn males are affected every year. And then Becker's is even more rare, significantly more rare than Duchenne's. And in 2007, 349 out of 2.7 million males between the ages of 5 and 24 had been diagnosed.
Our next question is, what are some causes of transplant rejection? So transplant rejection is caused when a patient's own immune system recognizes antigens from a transplant as being foreign. And the most notable is the T lymphocyte recognition of the MHC complexes.
Our next question is, what is an orthotopic transplant? This is when the transplant organ is placed directly in its normal anatomic space. The problem organ is removed to make space for the transplant organ. And another type of transplant is a heterotrophic transplant, which is when the organ is placed near the existing organ.
Questions down here?
There we go. So one of our questions was, how does cocaine and alcohol lead to elevated creatine kinase? Direct cocaine-induced muscle injury may result from markedly increased activity induced by cocaine. Severe arterial vasoconstriction can cause skeletal muscle ischemia and infarction in the same manner as cocaine-induced vasospasm causes myocardial, cerebral, skin, and digital infarction. An alternative mechanism is cocaine-induced inhibition of the reuptake of catecholamines at alpha adrenergic receptors, which in turn leads to high intracellular calcium levels in muscle cells and to subsequent cell damage and rhabdomyolysis. And with alcohol, there can be acute or chronic alcoholic myopathy. So acute alcoholic myopathy is a syndrome of sudden muscle necrosis and occurs as a result of binge drinking, whereas chronic alcohol myopathy is a more indolently evolving syndrome of proximal weakness and muscle atrophy that accompanies prolonged alcohol abuse.
You got their money's worth with that question, didn't they?
Okay, another one of our questions was, what is steroid myopathy? Steroid myopathy is usually an insidious disease process that causes weakness, mainly to the proximal muscles of the upper and lower limbs and to the neck flexors. Although the exact mechanism of the muscle pathology is unclear, it may be related to decreased protein synthesis, increased protein degradation, changes in carbohydrate metabolism, mitochondrial alterations, electrolyte disturbances, and decreased sarcolemma excitability. There are 2 types of steroid myopathy, acute and chronic. The chronic can occur from prolonged use of corticosteroids, and the acute is less common, associated with rhabdomyolysis, and occurs abruptly if a patient is receiving high-dose corticosteroids.
One of the questions was, what is Gower's sign? Commonly seen in patients with muscular dystrophy, a Gower's sign is associated with weakness of the proximal limbs, especially in the lower limbs. And so these, these patients can be seen helping or walking using their arms on their legs to help themselves to propel their legs forward.
Other questions?
Another question was, if this patient's urine was positive for blood on dipstick, what other than blood could most likely cause that? And if the urine dipstick was positive for blood, but there's no erythrocytes seen on the macroscopic examination, this suggests a false positive reaction and should be alerted to the attending physician about this false positive reaction. And if many epithelial cells are seen on a microscopic examination, it could also suggest some sort of contamination with the urine specimen.
Last question.
I think
Okay.
that was
The content of your presentation is very, very strong, and the depth of your research shows that. So again, we want to say, job well done. We just happen to have a person in the audience that has some depth, some knowledge, association with Dr. White, who knows a little bit about muscular dystrophy. So this is Dr. Rinaldi. Dr. Rinaldi is from Children's Mercy Hospital. He's going to talk to you a little bit about your case and a little bit about muscular dystrophy. Dr. Rinaldi.
Thank you. Yeah, great presentation, guys. That was really comprehensive in many ways, and you covered the important bases, I think, with respect to Becker's and muscular dystrophy in general. So job well done. Very, very good. Becker's is an interesting condition. We tend to see a lot more Duchenne's muscular dystrophy, as you guys noted. Becker's is a lot less common. But they do tend to have very similar clinical manifestations. With Duchenne's, you'd mentioned life expectancy being into the 20s. There's actually been a significant increase in, I think, life expectancy in Duchenne's over the past 15 to 20 years. When I first started practicing about 20 years ago, and I'm not going to age myself too much here, life expectancy for Duchenne's was about 17, 18 years of age. And we're now getting kids and young adults out of their 20s, and even some into their 30s now who have Duchenne muscular dystrophy. So when we counsel parents, and I'm glad you touched on that educational component, when we counsel parents who have kids with Duchenne muscular dystrophy, that's one of the things we want to touch base on is the importance of medical management in these kids, cardiac management, pulmonary management, contracture management. It really has boiled down to improving overall general health and managing those conditions, the comorbidities in Duchenne's that's led to this prolonged life expectancy in Duchenne's. And that's really important to parents. You know, you add 10, 15, 20 years potentially onto somebody's life. That's huge. That gives them a lot more quality. You know, they're getting jobs, getting married, so on and so forth. Becker's, on the flip side, obviously has a much longer, I think, life expectancy. Obviously, some of those folks getting out in their 40s, 50s, and even 60s in many cases. And that's where the cardiac transplant issue comes up. Because life expectancy is good, and weakness tends to be a lot less than what you would see in Duchenne's, that brings up the possibility of cardiac transplant being a very viable treatment option for the cardiomyopathy in that population. So most counseling does lean towards doing that, and then come up the ethical considerations of doing that, who's the appropriate patient for that, so on and so forth. But it is a very, very interesting condition. I've managed probably just, I'm going to say, 3 or 4 kids with Becker's over the 18, 19 years I've been in practice, so we don't see a lot of it. In fact, I saw one of my patients this week, and he's doing absolutely fantastic, plays basketball. He's 14 years old, is 6'2", weighs about 190 pounds, just a huge kid. My 13-year-old is about this tall, so a neat kid. Again, I'm glad you guys touched on the quality of life topics. Maintaining range of motion through contracture management, osteopathic applications are certainly big in this population as well. So again, job well done, guys. Very, very good.
Robert, thank you very much. That concludes our presentation this afternoon. And again, we want to thank everyone for attendance. And again, job well done. Thank you.